Good morning and good evening to everyone, and welcome to the Harvard Chan School of Public Health India Research Center webinar on From Smog to Sickness, Understanding Air Pollution in a Changing Climate. We'll begin our panel discussion very shortly, but before we do, I'd like to introduce the India Research Center of the Harvard THM School of Public Health, which was established in 2015 as the first global footprint of the Harvard Chan School. It works to advance health in India and globally through three strategic goals of research, training, and capacity building, and knowledge translation and communication. The center fosters collaborations between faculty at the Harvard Chan School, researchers, and students with their counterparts in India. It provides technical and research support to public health initiatives across public, private, and nonprofit sectors. The center is led by Dr. K. Vishwanath, the Lee Kumke Professor of Health Communication at the Harvard Chan School. The focus of this webinar and the series itself has been on climate change and health, science, policy, and public health in action. The aim of the series is to convene global and national experts to explore the relationship between climate change and effects on health. The discussions will focus on the current state of the science, gaps in our data and our prevention strategies, ongoing programs and interventions, and recommendations for strengthening public health responses in India. This webinar, the second in the series, will focus on the link between climate change and air pollution in India and the resulting health impacts that are being observed by populations all over the country. And to sort of moderate this discussion today, I'll be taking on the responsibility of managing this wonderful panel that we have with us. My name is Bhargav Krishna. I work at a think tank called the Sustainable Futures Collaborative in New Delhi. And my primary work is around air quality, both from the epidemiology as well as the policy aspects of the work. So to set the context, I have a few slides that I would like to share just to bring everybody up to speed on where we are with respect to the health burden as well as the policy ecosystem in India. So what we know based on work that has been done over the last couple of decades is that air pollution is a year-round and nationwide problem. On the right-hand side in the figure, what we have is the state-wise population-weighted particulate matter or PM2.5 exposure across the country developed for the global burden of disease estimates. And what we see is there is really no part of the country that meets the World Health Organization guidelines on safe levels of exposure to air pollution, even in states that are coastal or in much cleaner areas than expected. And of course, the regional exposures to air pollution in the Indo-Gangetic Plain far exceed even India's own much more relaxed air quality standards. Recent studies have shown that 82% of Indians are exposed to PM2.5 concentrations above our own ambient air quality standards. This results in about 2 million deaths every year attributable to air pollution. And of course, the Indo-Gangetic Plain remains one of the most polluted regions globally, not just in India. The regulatory challenge of air pollution is made much more complicated by the fact that we have a plurality of sources, both local as well as regional and transboundary. And our regulatory institutions really struggle to manage the issue given their capacity constraints. And over time, the excessive amounts of focus that have been provided to the issue in the national capital region of Delhi has taken away from attention that should be addressed across the rest of the country as well. The end result of all of this, of course, the burden of disease from a mortality perspective is important, but it's also important to contextualize what that means with respect to other traditional risk factors. And what we see is that the air pollution exposure, both from household as well as ambient sources, is the number one risk factor for deaths in India, over many more traditional risk factors, including poor diets, high blood glucose, malnutrition, and poor access to clean water. Now, the response to this particular intractable challenge has been characterized in largely three overlapping generations of action. The first, of course, was driven by public interest litigations and ad hoc policies targeting specific issues primarily around the national capital region. So we had big initiatives such as the transition of all public transport within the national capital region to compressed natural gas from diesel in the early 2000s. Relocation of brick kilns and other polluting industries and thermal power plants in and around the region as well, resulting in some prominent gains that were made in the early to mid 2000s, especially in advance of the Commonwealth Games in Delhi in 2010. The second generation of action is more between the periods of 2010 to 2016, 2017, where The subsequent focus was on banning particular polluted fuels and setting sectoral targets for certain actions. So, for instance, leapfrogging emissions norms for internal combustion engine vehicles and expanding India's focus on the use of electric vehicles both for public transport as well as personal transport. So, personal EVs have proliferated quite substantially. Anybody who walks the streets in Delhi would be able to see the number of electric two-wheelers and four-wheelers that are now being widely used. The most recent generation of action has been between 2017 and the present, where the focus has shifted to cities as the foci of action with the launch of the National Clean Air Program in 2017 and its start in 2019, which really channeled close to $1.3 billion in funds to 131 cities across the country with a focus on reducing PM10 by 2024 by 30% and by 2026 by 40% or meeting the national ambient air quality standards. Coupled with this has also been an increased focus on winter and exposures in winter, which are particularly high. So to give people context, our ambient air quality standards for daily exposure, 24-hour exposure are set at 60 micrograms. WHO standards are set at 15 micrograms. A normal winter day in Delhi and in much of North India ranges anywhere between 150 and 300 micrograms of PM 2.5. We've also seen a proliferation of various silver bullets based on experiences globally and sort of ill thought through interventions locally. So things like smog towers are essentially air purifiers that filter the ambient air, smog guns which spray water, particularly on polluted sources, and management of crop residue through ex situ and in situ interventions, which don't necessarily address the root cause of the problem. And most recently, this particular winter, what we've seen is experiments around cloud seeding to make it rain to reduce the air pollution levels. Now, where are we now after all of this work? So, in the last 5 to 7 years, we've seen a substantial increase in the awareness around air pollution and its health harms, particularly in the northern belt of the country and in other major metros around the country. We've seen stories more recently around the high levels of air pollution in places like Mumbai and Pune. We've also seen a rapidly expanding health evidence base. There's substantial local research now on both cardiometabolic and respiratory diseases, on prematurity and birth outcomes, and on mortality from air pollution exposure. There's an expanded policy space. So we have both the NCAP and city action plans, which are now in place across these 131 cities, and creation of new institutions such as the Commission on Air Quality Management for the National Capital Region. We have monitoring now in areas where they didn't really exist before. A majority of the 131 cities under NCAP did not have a single monitor that would report routine air quality data. We also have a proliferation of low-cost sensors, which are expanding our ability to understand what localized hotspots look like and to cover rural and peri-urban areas where regulatory monitoring doesn't exist. And the amount of funding that's been committed to air quality management has been substantial, not just directly from the Finance Commission and the National Clean Air Program towards cities and city action plans, but also sectoral funding that has been provided to sectors such as the transport sector for purchasing of electric buses, electric vehicle subsidies, and for crop residue management. But there are still areas that we really need to improve. The first issue is that practicality really guides decision making. So, for instance, the choice of pollutant that we regulate for NCAP has been shifted from PM 2.5 to PM10, and that brings with it a series of concomitant actions that are primarily focused on managing dust and not particles of combustion. We've also prioritized the least inconvenient policy actions, example, managing road dust. The question of a missing health frame continues to remain an issue where our understanding of health science is really lacking in our environmental policy making, and the bar for evidence is set quite unreasonably high. And of course, coupled with all of this is the institutional capacity and accountability issues that mean that in a federal structure with a plurality of sources and the complexity of intersectoral action, no one person is really accountable, and our regulators are dealing with a 21st century problem with a 20th century institutional design. Now, with that, I'll stop sharing my screen and I'll move over to our panel. And we have an eminent panel to talk about these issues today. But first, I'll introduce our first speaker, who is Dr. Poornima Prabhakaran. Dr. Prabhakaran is the director of the Center for Health Analytics and Research Trends at Ashoka University. She is also deputy director and head of environmental health at the Center for Chronic Disease Control in New Delhi. In addition to her extensive research portfolio on the effects of environmental exposures on children and adults, Dr. Prabhakaran is also a Lancet Commissioner for Sustainable Healthcare and is a member of technical groups that provide inputs to national and subnational programs and policies for climate change and air pollution through the National Program for Climate Change and Human Health. Welcome, Dr. Prabhakaran.
Thank you, Bhargav, for that very generous introduction.
So we'll do this in two rounds of questions that I'll pose to each of you. So we'll have a panel discussion for about 35, 40 minutes, and then we'll open it up to questions for the audience to pitch to you. And for our audience members, any questions that you would like to pitch to our panel, please just drop them into the Q&A box and we'll pick them up at the end of the conversation. So Poornima, you've witnessed firsthand the development of the evidence based around air pollution's health harms. In India, you've been front and center in some of the studies that have contributed to the development of the evidence base. Now, a decade on from when we perhaps started some of this work, we are at a stage where new studies are being published week on week on a range of health impacts. This is sort of a three-part question. I guess, given the context of this conversation, what do we already know about the harms of air pollution on health, specifically in India? Where could we still improve our understanding? And is the bar of evidence for action already met?
Yeah. Thank you, Bhargav. Good evening and good morning, everyone. Thank you to India Harvard Research Center for the opportunity to be a part of this conversation. Bhargav, to answer your question, I just, want us to step back like a decade ago. I think when the year 2016, I think, which most of us who live in this region know as one of the worst air pollution episodes that we saw in the Delhi NCR region. And back then, I think the conversations in the Houses of Parliament and everywhere else was, we do not have contextualized evidence for the health effects of air pollution. And we're relying on global burden of disease estimates. And cut the story short, 10 years hence, I think that story has substantially changed. You were right. I think papers, the research is coming out every week on the health effects of air pollution. And I think we've come a long way in building that evidence base, that repository of evidence, homegrown evidence, if you like, on health effects of air pollution. I think we've filled several gaps in that space. And today we know from studies that are conducted here in India, in areas that are not only just high pollution zones, but also across the country, even in the so-called clean air cities. And there's a lot that we can fall back on in terms of the evidence base. For example, we have evidence here in India from our own longitudinal studies, the cohort studies that have established that exposure to particulate matter, the culprit pollutant PM2.5, is linked to risk factors for cardiometabolic disease like hypertension, fasting glucose, lipids, and to mortality. And I think it's not just in one or two places across the country. We have a national model now that has come a long way actually in examining those associations of health effects across a number of other health outcomes. So we know, for example, on pregnancy outcomes, the adverse birth outcomes, we're also investigating now links with cancer and stroke. So I think it's not right to say that we don't have evidence. I think we still hear it, that there is no evidence of health effects on air pollution. I think it's just the willingness to accept what is there for us to see in terms of evidence. And we do have enough now to show. In terms of setting the bar high, what is high? I mean, we in fact, our group is currently working on linking air pollution, temperature, other risk factors, environmental risk factors, to a host of health outcomes across life stages, from pregnancy to the elderly age groups. And I think that has stood the test of time. I mean, there's rigorous epidemiological methods, and we certainly have enough to fall back on. I'll stop there, but I hope I've answered the question.
So if I can just sort of have a follow-up to that, I think one of the things you mentioned was the synergistic effects of both exposure to air pollution and heat. And I know that that's given the focus of this webinar on both climate and air quality. Is there something you can speak to on the recent work that you've published on the synergistic impacts of co-exposures to air pollution and heat?
Yes, certainly. I think oftentimes even researchers, get confined to siloed approaches of investigating the detrimental effects of health by looking at one risk factor. But in reality, we all know that we live in environments where we are exposed to multiple stressors at any single point in time. And I think a classic example is where we live in India and in Delhi, for example. At the same point in time, we're exposed to poor air quality, but also extremes in temperature. And it was exactly that stimulated us to kind of investigate the synergistic effects of air pollution, particularly PM 2.5, and temperature and extreme temperature. And I think we used our own in-house models, which is a very fine spatio-temporal resolution model that we have for the entire country, and data from 10 Indian cities, diverse cities. We had daily death data from these 10 cities for a decade, 2008 to 2019. And while we understood already that there was a positive association of increasing PM 2.5 levels or ambient temperature on mortality, what we found was that this effect on mortality was amplified when there was coexisting risk factors. So for example, when the PM 2.5 risk on mortality by itself was about 1.4% in these two cities, at the time when the temperature increased from, for example, 75th to 99th percentile, that risk in mortality was amplified several times over. So, and vice versa. At high temperatures, the effect of PM 2.5 is higher, and at higher PM 2.5 levels, the effect of temperature on mortality is higher. So there is definitely amplified effects when there are coexisting exposures.
We seem to have lost Poornima for a second. But Joel, I'll move over to you and just a brief introduction of Dr. Joel Schwartz, who's a professor of environmental epidemiology at the Harvard T.H. Chan School of Public Health. Dr. Schwartz's research career spans multiple areas of inquiry and has led groundbreaking work that established the health harms of both lead as well as air pollution, directly contributing to their regulation by policymakers in the US and elsewhere. Joel's work these days focuses on both the acute and chronic exposures to air pollution and developing exposure models that serve as a public good and as a basis for researchers in the US and India to use in conducting epidemiological studies. Welcome, Joel.
Thank you.
So
go ahead.
Please. No,
Sorry.
please go ahead.
Well, I just wanted to start with a few words about air pollution. Because I think that the strategies in India and in other parts of the world as well to address air pollution have tended to focus on local issues, and that misses the point. We need to pay attention to the physics first. Combustion particles are so small that they stay suspended in the air for 1 to 2 weeks. Now, if you've ever watched a weather forecast and you see a storm move across the country in a few days, well, that's true for air pollution also. Those particles can move across India in a few days. But if they stay suspended in the air for a week to two, that means that a lot of the particles in Delhi come from places upwind. And it also means that focusing on the terrible air quality in Delhi forgets the fact that the air over Delhi today is going to be over someplace downwind tomorrow. And if we think about ozone is formed chemically in the atmosphere by reaction, and that takes time. And so ozone concentrations are always downwind of the emissions that produce the ozone. And coming back to particles, many particles are also formed by secondary reactions in the atmosphere. So, moving coal-burning power plants 100 miles away from Delhi, the sulfur dioxide that comes out of the stack converts to particles at a rate of about 3% per hour. So by the time all of that SO2 has turned into particles, the air is, it's been a day or two for that to happen. And the air can be 1,000 kilometers away by then. So focusing on a given place with strategies is just not an effective way to deal with pollutants that are actually regional in nature because of this transport. And as you mentioned, focusing on PM10, which includes relatively harmless stuff and triggers relatively useless policies, is a big mistake. And the recent clean air strategies in India have focused on, a set of highly polluted cities. But when we I don't know if I can share slides or not. Can I share my screen?
Briefly.
Yeah. Okay. So this is air pollution in India in 2019. This is the annual average. And you can see it's not just Delhi, the entire north of India has high air pollution, right? And, and other places also have relatively high concentrations because things move. And what is the consequence of this? So this is a study we did where we took mortality from every district in India and we looked only at year-to-year changes within a district in mortality rates and year-to-year changes in air pollution. So, and this is the dose response curve we see, and you can see increased mortality rates down to the lowest concentrations we find, at a concentration of 35, we're seeing 20% higher death rates than at a concentration of 12. So,
and 35 is below our annual average standards as of now.
So let's see, I need to stop sharing there. Sorry. So that's the situation. The air pollution is all over, and the health effects are really well established.
Got it. And perhaps a small follow-up to that. I mean, you studied this globally, both in sort of developed and developing nations. We often hear the need for sort of more local evidence, and this is part of that local evidence. But if we're looking at the magnitude of exposure response in India compared to some of these other countries, are we seeing any substantial differences? And are there factors that make Indians either less or more susceptible to this?
Well, globally, what we see in terms of the exposure response relationship is it's steeper at lower concentrations, and then it tends to become less steep at very high concentrations. So, in fact, in India, where concentrations are quite high, we're seeing a lower sort of marginal effect of a change in 1 microgram than we see in the rest of the world. But that's consistent with studies we've seen in the rest of the world. And if air pollution levels come down in India, that slope is going to get steeper as we get into that other range. As for factors that modify the effects of air pollution, one factor that we've seen in many studies is diabetes. We find that people with diabetes are more susceptible to the effects of air pollution, and diabetes rates are high and increasing in India. So that's a concern for the future.
Thank you, Joel. I'm happy to welcome our third panelist, Dr. Amruta Nori-Sarma, who is an assistant professor in environmental health and population sciences at the Chan School. Dr. Nori-Sarma studies the relationship between environmental exposures associated with climate change and health outcomes, especially in vulnerable communities. Dr. Nori-Sarma also serves as one of the leads of the CAFE Research Coordinating Center, a joint effort with the BU School of Public Health that aims to bring together and amplify the work of researchers assessing the health impacts of extreme weather events. Welcome, Amruta.
Thank you so much, and thank you for the opportunity to join for this webinar.
Thank you. So, Amruta, some of your recent work has focused on, I guess, since Joel mentions the susceptibility of people, especially with chronic diseases, some of your recent work has focused on the impacts of chronic exposures to ambient air pollution and on COPD, especially in older women. India is still a relatively young country demographically, but given the exposures in both household and ambient settings, we've seen sort of disproportionate impacts, especially on women. We're also more generally seeing a growth in the prevalence of chronic diseases such as hypertension and diabetes amongst our urban populations. So as we see the sort of population beginning to age over the next few decades, what do you see as the sort of risks with respect to the air pollution burden of disease?
Thanks. That's a really great question. And so the work that you're referring to is a study that we've done in a cohort across the United States of elderly women, the Women's Health Initiative cohort. And I think that, first of all, one of the things that I want to mention, just following up on the comments that we had from Poornima and some of the comments that we had from Joel as well, there have been some tremendous advances in the last 10 years in air pollution studies, especially done in situ in India. And I think that this is really important because, the thing that I should highlight about the study that we've conducted in the United States is that ambient air pollution levels, even over the course of the past decade, with respect to PM 2.5 and nitrogen dioxide, has been relatively low. So when we're looking at increases in the interquartile range of PM 2.5 exposures for populations that are in the US, we're looking at a different set of exposure risks. And I think that's important to highlight because for a long time, we didn't have a lot of evidence that was generated at the upper end of these PM 2.5 exposure response curves. So we were really extrapolating based on information that we were getting from other sources of pollution. For example, for a long time, our estimation of what happens at the upper end of these risk curves was based on tobacco smoke when we see people having exposure to relatively high levels of PM 2.5 due to smoking or environmental tobacco smoke as well. So now we're starting to see a build out of the evidence base around what the hazard is and what the risks are in this upper end of the exposure distribution. And I think that's really important to underscore, even from what Poornima was saying earlier, have been some of the advances in the literature and in the risks that we're seeing of air pollution exposures. The study in the Women's Health Initiative cohort found that there were, in fact, increases in the risks of COPD among women over age 65, according to increases in both PM 2.5 and in nitrogen dioxide. The other thing that I think is important to mention is that we leveraged a mixtures model approach to look at the simultaneous impact of joint exposure to PM 2.5 and nitrogen dioxide. We also did look at ozone, although the results there were a little bit more mixed. As Joel was saying before, ozone is created through this chemical reaction in the atmosphere, and it has a tendency to behave differently in terms of the pattern of exposure compared with something like NO2 or PM 2.5. And what we found is that there is a synergistic effect also of exposure to multiple pollutants simultaneously. So I think that kind of underscores also what Poornima was mentioning earlier, that our methods are advancing not just in our capacity to look at the higher end of the exposure distribution using data that's locally relevant and that's contextual in India. We also have advances in the methods to look at joint exposures And now what we're starting to do is push even further in this space of mixtures to look at the climate stressors and the air pollution stressors. So one of my primary areas of focus is how do we envision and how do we contextualize and estimate what it means to be jointly exposed? So is it just that you have two different air pollutants in your airspace, or is it that the temperature is changing differentially and that's leading to different reactions in the atmosphere? Could there be cascading hazards? Could there be a monsoon season that gets delayed because of issues in the atmosphere that correspondingly leads to differences in the ways that people experience air pollution exposure, because previously it would have washed out with precipitation and now people have a longer dry period where they're exposed to PM 2.5. So I think these are some of the continued questions that we have. With respect to vulnerability in the population, I think it is the case also that context in that situation matters as well. It's really important when we're identifying some of these chronic illnesses to look at what access people have to care, what are the options for treatment, and how could those potentially be different if you have development of COPD and asthma among older women that is a result of the long-term chronic exposure to air pollution. And I think, one of the things that we hope is that by clarifying the environmental risks, we can correspondingly provide opportunities for differences in the ways that the outcomes are being treated as well, and maybe try to mitigate some of the environmental stressors that might be contributing to the onset of new illness or exacerbating people's existing chronic illnesses.
Thanks, Amruta. And I guess perhaps related to this, I think it's interesting. I mean, my own curiosity is thinking about what would a regulatory regime that focuses on multi-pollutant exposures look like, and how would it be different from focusing on individual pollutants that we regulate directly. But I think as aside from that, I think the sort of thing that I'm thinking about as you're talking about this is we are still sort of far behind when it comes to thinking about these issues. You just heard from Joel as well as Poornima that we're still regulating PM10 as the sort of pollutant of interest, and there's a long way to go before we're able to generate the amount of environmental risk factor data locally from a monitoring perspective, not just from a modeled exposure perspective, especially for gaseous pollutants, for instance. But if you were to sort of in that context, if you were to chart a sort of research agenda for where we do perhaps need to strengthen some of our work on the sort of exposure assessment and the epidemiology side going forward, what are sort of one or two priorities that you would be thinking about? And perhaps associated with that, are there capacity building needs that we need to fill as well, both from a sort of technical standpoint as well as a sort of research capability standpoint?
Yeah, that's a great question. I think that one of the things that's really important is establishing the baseline for building of evidence, right? So the regulatory frameworks, and this is the case whether you're in the US or whether you're in India, it's kind of a common gap, maybe I can say, in how we can envision public health impacts of air pollution exposures. The regulatory framing for air pollution measurement leads us to even place our monitors in specific locations, right, in order to ensure that people are in compliance with the regulatory standards. And so they may or may not be fully representative of the experiences that people have on the ground, right? And so this is why, models such as the one that Joel showed earlier in his slides are so useful, because they're taking and integrating all of this information across land use characteristics, across different types of measurements, alongside the regulatory monitoring to really help to provide a more complete picture of what people's experiences are with the air pollution exposure in their own neighborhood or in their own environment. And the model that we've been working on in collaboration with Poornima and Joel and other folks across this collaboration to provide the highly spatially and temporally resolved PM 2.5 exposures for the entire country on a daily level, it's really helping to fill in some of those potential gaps, right? So then when you're looking at the follow-up for the health studies, you can provide information that's not just based on evidence from the nearest available regulatory monitor, but maybe takes into consideration some of the built environment characteristics, some of the other land use characteristics, and gives people a perspective of this is what we estimate as the air pollution level in your neighborhood, in your environment. And I think, building out that environmental evidence base can be done. We aren't regulating other types of pollutants right now, but there may be opportunities to build on. We did a study in South India and Mysore looking at deployment of low-cost sensors to be able to measure on a high spatial and temporal resolution, or the temporal component was seasonal, but we were looking at nitrogen dioxide. And there has been a growth in local studies that have been developing that kind of base for evidence. And I think that that's part of the first steps towards demonstrating that there is a need for additional pollutants to be monitored. And I think once we have the information and the evidence base, not just on the distribution of the air pollution, the different species, the different chemical constituents of the air pollution, it becomes easier to argue that we need to look at these things holistically in the more multi-pollutant framework. And also it becomes easier to document the health harms in order to support future regulatory activities, right? So I think it's a stepwise process, but I'm encouraged to see that we're starting in that direction.
Thank you so much, Amruta. So Poornima, I guess it's a natural segue to the talking about really the next phase of air pollution policy making in India. At the end of this year, we'll be closing out the first phase of NCAP, which set a target of reducing PM10 levels rather by 40% by the end of the 2026 calendar year. And the talk is that there is likely to be an NCAP 2.0, which sort of builds on the limited successes of NCAP 1 and learns from some of the missteps that have been taken in this particular phase of the work as well. So given your sort of engagements with government, especially from the health sector perspective, and working with government on raising awareness as well as training physicians and a lot of other activities with respect to managing air pollution in India, if you were to sort of propose from a health sector perspective, what needs to change with respect to an NCAP 2.0, what would that look like?
Yeah, thank you, Bhargav. Very important question. I think many of us know whatever happened with NCAP 1 did not have too much of a health lens as we would have liked it to. And I think also the focus on PM10, but in light of all the evidence and the research that has come out in recent years, I think one for sure, the focus on the so-called non-attainment cities, the 130 non-attainment cities. I think there's work that came out of our group which showed that this is beyond that one, that the so-called cleaner cities in India are also vulnerable, at very low levels of pollutants. Joel was explaining the curve. So I think for one, we have to change the lens from the target cities that we are looking at. It has to be a bigger lens beyond the non-attainment cities. Second, in light of the evidence on PM 2.5, I think that's enough evidence to kind of say to move the focus away from just looking at PM10. Thirdly, I think there are some cases where things have improved. I think the paper I was referring to was about the hotspots. There's emerging hotspots and declining hotspots in several parts of India. So the lessons to be learned from those so-called declining hotspots, what worked over there, maybe something that we could kind of fall back on in evolving the strategy for NCAP 2.0. And I think certainly the revision of the standards itself, like, we know now, like you said at the beginning, 80% of the country is living in areas where, exceeding the guidelines. So I think revisiting some of those guidelines, taking a health-centric lens is also important. I think we have enough evidence now to feed into that kind of a discussion. We cannot have thresholds in a way, but at least those lowering those standards has to come from the homegrown evidence we have now.
Understood. Thank you. So Joel, we've seen sort of conversations around the bar for evidence and sort of questions around whether Indians are somehow different from people in other countries, but we're also living in an era globally of sort of science denialism. We're talking about people contesting climate change, the established science around climate change, or increasing vaccine hesitancy, even to sort of routine vaccinations that have been delivered in the public health system for the last 50 years. You've had a sort of insider's view, both as an epidemiologist and within a regulatory agency, having worked on both the science of lead and on air pollution and its impacts on health. given those experiences and sort of the fallback that's happening right now towards sort of silver bullet or glamorous in the words of one of our attendees, solutions that are preferred rather than the sort of hard task of managing a complex issue, how would you sort of relate to some of those experiences back in the day to what we could do now locally?
Wow. Well, so first of all, public opinion is crucial for all of this. We started controlling air pollution significantly in the US because there was a movement in the late 60s and early 70s where people were very concerned about environment and health. And that created a regulatory structure at EPA and laws that said that standards needed to be based on health and a system for reviewing them that went forward for many decades, successfully reducing air quality, reducing air concentrations. Um, and when we worked on lead and gasoline, it was in that context. And when we got a lot of attention by public media to the health effects of lead, that politically forced the Reagan administration to do something about it. Now, what industry learned from that is you need to cast doubt on the science, right? And sometimes that's successful and sometimes it isn't. You know, 15 years ago, Delhi and Beijing were sort of similarly polluted. But what happened in Beijing was when the US Embassy put online the readings of air pollution from the embassy monitor, it generated a huge amount of public pressure on the government to do something to lower it. And so they did. Now, the readings in Delhi were also put online, but the amount of public pressure generated was less. And so the impact was less. So the issue of getting governments to do something when industry doesn't want to consists of getting the public mobilized to demand that the government do it anyway, right? And that's a complex question. And certainly industry has learned over the last decades how to generate confusion about what the science is. And so what we need to do as scientists is to go out and generate more public attention to the results of our study to try to counter it. And so the latest things that we've heard for air pollution as well, these are just associations, they're not causal. And that's why in the studies in the 10 cities that Poornima spoke about, we used causal modeling. We fit marginal structural models. And in the study that I showed you, we used causal modeling. It was a difference in difference analysis. Now, those are subtle things that you're not going to spread to the public. That you can only get through legal systems to say, well, we did this, we see the same thing. But I think the big message is air pollution will come down when the public demands it. And that's true in every country.
Yes, that's kind of a philosophical note to end on as well. But let me turn to our audience and a few questions. So, Amruta, may I come to you with this one from an anonymous attendee, which is wanted you to elaborate a little bit more on the impacts, particularly of air pollution exposure on pregnant women and young children. How do we know that they are perhaps more vulnerable to exposure than say regular adults?
That's a great question. I think that there have been some studies that have looked at various stages. As Poornima mentioned, we've looked all the way from pregnancy through the entire life course. There have been some studies that have been very interesting, even looking at the impact that air pollution has on fertility and fecundity. That's one area of work that's ongoing that just demonstrates that air pollution has an impact on rates of conception in addition to the later pregnancy outcomes. So looking at things like low birth weight and small for gestational age. We call them now small and vulnerable newborns. A lot of the focus in the air pollution and reproductive health literature has really focused on the neonates. But more recently, there have also been some research efforts that have looked at pregnancy outcomes specifically in the maternal side and the impacts on maternal health. So things like gestational diabetes have been examined. And some of the postpartum health outcomes that women experience after giving birth. And these are all things that are in progress. And I think a lot more studies are needed. But overall, it has shown that neonates are particularly vulnerable. And some of those birth outcomes that are experienced by infants have also implications for longer term health outcomes as well. So it's important to remember that this early life evidence that we're providing of impacts on birth weight, preterm birth, small for gestational age, some of the other more rare health endpoints among infants. So things like developmental issues and organ development, especially. Those have implications for later in life outcomes across a wide spectrum. So childhood obesity is one good example. That maybe has linkages to some of these pregnancy and birth outcomes. So I think once again, my perspective is that it's important to look at these things holistically. So I encourage people to start incorporating studies within cohorts and particularly within vulnerable cohorts, and maybe use that as evidence to continue looking across the life course, because I think the more evidence we can have of the early life health impacts of these air pollution exposures and how that's having continued knock-on effects in addition to the onset of new illnesses as people age. I think this set of evidence is going to be increasingly important.
All right, thank you. Poornima, a question to you from Ritu. Trying to understand basically the differences between risk in urban and rural areas from exposure to air pollution, and whether household air pollution perhaps in an interactive effect increases the risk of exposure, especially for households in rural areas, and sort of also relating to your experience of translating some of your work to local policymakers, and how has that experience been so far?
Yeah, thank you. Thank you for that question. So in terms of differences in urban-rural risks, I think for the longest time, I think the sparse monitoring networks in rural areas were the kind of the gap in studying the rural areas. But thanks to the models that we have now developed, we are able to kind of, take into account even the rural areas. And I think this is work in progress, definitely in our work currently in what we call our GeoHealth Hub. We are looking at adult cohorts, across urban and rural sites, and a range of health outcomes, especially with respect to cardiometabolic risk. So we will be attempting to investigate those differences between urban and rural populations. And I think in terms of the contribution of household pollution, I think indoor air pollution is definitely a big contributor in terms of individual level exposure, and definitely in rural areas that are still so dependent on the use of unclean fuels for cooking and heating. There's going to be, at least the speculation, of course, is that there's going to be that added exposure to people in these environments. And I think your last question, I think, Bhargav, was in terms of
translating your work
policy. I think I'll quickly pick on an example that we have used in terms, drawing from one of the analysis that we did, for example, for the city of Delhi, linking exposure to PM 2.5. and hypertension risk in our a cohort that we've been following up for almost 15 years now. And what we found that was for every 25 micrograms increase in the particulate matter, the blood pressure of the individuals increased by 3 to 5 millimeters of mercury. That said, I think when we talk to policymakers, it's a different language that we have to use. And what we've tried to tell them is if you reduce the air pollution in the city of Delhi by 25 micrograms, say from 100, an average of 100 PM 2.5 to 75, the prevalence of hypertension in the Delhi population will decrease by anywhere from 5 to 15%. And that's a whopping statistic in terms of the impact it can have if you do the upstream management of air quality well, you can turn away that many people away from the health system to access care for hypertension. So that translates into savings in terms of healthcare as well. So I think taking that a little further and showing them the benefits in terms of the economics, the cost savings in terms of averting disease burden is a good language that policymakers understand. In terms of uptake, well, we keep trying. The research is there, the right narratives are always being attempted, and we hope that will be incorporated into, for example, the revision of air quality standards. This kind of research is definitely very insightful. I hope I've answered your question.
So we have a few minutes left, so I'll take a couple more questions. So Joel, I'll pitch a question that's from Chinmay, but slightly modified, which is sort of looking at the sort of intersection of meteorology, climate change, and air pollution. And she pitches this question in the context of Mumbai, where sort of warming climate is altering dispersion patterns and sort of limiting the dissipation of air pollution that's generated in Mumbai. And are there things that we need to be cognizant of as we're looking at modeling air pollution going forward with respect to understanding what climate forecasts look like and what that means for local weather effects as well in enhancing exposures?
Sure. Thank you. So obviously, meteorological patterns have a large effect on air quality. And in Mumbai, we've seen changes in which areas have the highest pollution over the last 10 years when we looked at our model. So our models do take into account meteorology, wind patterns, wind speed and direction, and all of that stuff. Our models aren't forecasting, they're backcasting. They're saying what's happened, right? But looking at the influence of these factors, we can certainly conclude that if wind speed goes down, air pollution is going to go up in Mumbai, for sure. And if the directions change, the places where air pollution is higher are going to change within the city. And, when we did that, our model is on a 1 kilometer grid, so we saw hot spots in Mumbai. It's not like the whole city has the same concentration, but we saw that they were changing over time, and that'll continue to happen. And one of the things that's going to happen with climate change is I mentioned that some of the particles and all of the ozone are due to chemical reactions in the atmosphere. Well, think about basic chemistry. Chemical reactions happen faster when it's warmer. And so we're going to see more air pollution as it gets warmer because we're going to see more of this chemistry going on. And so there's definitely going to be an interaction. And we've done models in the US where we've shown that the concentrations of ozone and to some extent PM 2.5 have increased over the last 20 years due to the changes in temperature, and we've published those studies. And, That's chemistry, right? Chemistry is the same in India and North America, right? So that's going to happen in India as well. Um, and then we've also seen, as other people mentioned, these, Amruta and Poornima, interactions between temperature and the effects of air pollution. So you're going to get more air pollution and you're going to have these interactive health effects. So that's not a good situation. And I mentioned we see people with diabetes more susceptible to air pollution. We've also shown that people with diabetes are more susceptible to heat. So we're not looking at a situation in the future that if things stay the same, it's going to look pretty grim. And that's another reason why we need to do things to reduce the effects by reducing the exposure.
Thank you, Joel. I guess, Poornima, perhaps the last question, just to round it off, maybe 60 seconds. I think there was a question on understanding, okay, we know there are things that policymakers need to do, there's things that epidemiologists and those of us working on the health side need to do, and there's things that industry need to do, but what can individuals do from a behavioral lens if they want to contribute to reducing air pollution?
I think there's lots of different things that we can do. I think one is, at individual level, of course, be aware of the pollutant levels and avoid exposure is one thing, but also the interventions that you can do, avoid, the vehicular pollution by taking public transport. I think avoiding the use of unclean fuels, that's particularly for the rural areas, but even in urban slums and places, you see people falling back on those options despite cleaner cooking options that are there. And of course, burning of waste, and which is something that happens a lot in cities like Delhi, especially in the peak winter. I think those are things that are at individual level that we can try to do. But beyond that, I think it's also ownership and accountability at a higher level. Also, that plays an important role.
Great. Thank you so much, Poornima, and thank you to all of our panelists today. Thank you, Joel, Amruta, as well, for a fascinating discussion. And I hope we've provided some food for thought to our audience and perhaps set some minds racing with respect to what they could all contribute to perhaps future work around air pollution and health. I want to take a moment to thank you all and the Harvard Chan India Research Center for organizing this session. And please do follow their social media handles to keep up to date on what other events are going to follow, especially in this series. And thank you again for joining us this evening.
Thank you.
Thank you.
Thank you, Bhargav.